Good evening, Mohammed.
Good evening. Hi. Can you hear me?
And it's here.
Go ahead. Good evening.
This is Iman.
I have contacted you several times. I'm sorry for time delay.
No, that's okay. Okay, thank you.
We are very pleased to have you with us today.
Okay, all right.
Okay, so sorry for a little bit of delay, and this online meetings, we're getting used to it anyway, in spite of all the delays and the disturbance. But we and you and all over, we are obliged to it, so we're getting used to it. So, are we back, all of us? Mohammed, we're today meeting, celebrating the 20 years start of the LDLT in Egypt, in Cairo, in Egypt, and performing 1,500 cases over the last 20 years. We are here in Ain Shams University, the Faculty of Medicine, Ain Shams University in Cairo. Our surgical group that I was honored to lead it for the last 20 years. Now we have my colleagues taking over, all the professors you're going to meet in a few moments. The surgical team who started in another hospital was in Wadi Nil Hospital in 2001 to 2006 when we shifted to Ain Shams University, but we are still keeping the practice in Wadi Nil beside Ain Shams as well. So the surgical team was 100% in several centers in Egypt stemmed from Ain Shams University, and we gave a hand to several of our colleagues elsewhere in the country. We used to do, of course, adults and pediatrics. The pediatric program have been halted a little bit because my dear friend, Professor Ala Faiz, who was an excellent pediatric surgeon. I'm an adult surgeon. He was a pediatric surgeon, and he was the one who started with me. He passed away dramatically in an accident early 2012. So for the last 8 or 9 years, there has not been real lead in pediatric liver transplant within our group. We have a good pediatric surgery group and department in France, and some of them will be with us today as well to listen to, but we are all eager to listen to your great experience in pediatric liver transplant in Kings, in England, or in India, in Chennai, and being now you are the president of the ILTS. It's a great privilege and honor for us to have you with us. Everybody's really anxious and eager to hear from you. The audience are not a lot because you know the COVID-19 restrictions, but you have all kind of audience, all specialties, the surgeons, anesthetists, intensivists, hepatologists, radiologists, everything. And let me present for you. I have the honor to present for you all today Professor Mohammed Rella, who's the lead surgeon in Chennai, India, and he's current president of the ILTS. And I had the pleasure to meet him several times in congresses around the globe over the last 20 years. Before moving to India, he worked a great deal in King's College in London, and everything, adult pediatric, but of course his subspecialty and his main interest in the pediatric age group that we really, all here in Ain Shams, we are looking forward to make a sort of revival of it. So Dr. Mohammed, the floor is yours, and take your time. Thank you.
Thank you. Thank you very much. You're being very kind, and it's lovely to see how your programs have developed so well, actually. In the Middle East, I think Egypt has been one of the leaders in the field of transplantation. As you know, I've also visited Egypt many years ago, 15 or 20, almost I think 18 years ago. We have wonderful memories of the place and the food and everything there. Now, I moved to Chennai about 10 years ago, back home. That's where I studied, and that's where my parents, my mother lives. And I find that it's been a huge opportunity for me to be back in India and serve really my own people, where the need for liver transplantation is huge. I have a recorded lecture. You can start playing it, and then we can talk. We can talk further in the question and answer session. Okay. Good afternoon. Hi, my name is Dr. Mohammed Rela. I'm one of the surgeons, liver transplant surgeons working in India currently. I want to thank the team of Ain Shams Center for Organ Transplantation for completing 1,500 cases. And I also want to thank the organizers for giving me an opportunity to present on my experience of pediatric transplantation. Over the last 30 years, I went into transplantation almost 30 years ago at King's College Hospital. Now, pediatric transplantation is probably one of the most satisfying of all the operations, because you see children improve very rapidly and they do very well post-transplantation. But setting up pediatric transplantation requires really very dedicated and committed surgeons and pediatric hepatologists and a pediatric intensive care unit. And it should not be taken very lightly, as it will have an effect on the outcome. I went into King's in 1991, and even at that time, it was a specialized unit for pediatric hepatology. And there were professors who were interested in pediatric liver diseases, and I had the opportunity to work with Professor Alex Mowat. He was one of the pioneers in pediatric hepatology, followed by Professor Georgina Bergani, and my colleague Nigel Heaton and I had a huge interest in pediatric transplantation. As you all know, the first attempt at pediatric transplant was made by Professor Thomas Starzl. In fact, the first transplant, the first ever human transplant done, was a pediatric liver transplant. Unfortunately, the early outcome was not good, and the child died on the table with bleeding. And subsequently in Europe, pediatric transplant was really popularized by Professor Ott. I've had many opportunity to speak to him and interact with him on pediatric transplantation. And in fact, during his retirement, I was in fact talking about split liver transplantation in his retirement function. And that was again one of his interests. And we shared common interests. And this publication from Professor Ott shows that the results, the outcome of pediatric transplantation has improved steadily over the decades. If you look at the 80s, the outcome probably was around 65% survival, and with the 90s and now with 2000, you can expect to have at least 1 year survival of close to 95% in the pediatric population. And that's also earlier do better than adults. And when you look at the survival curve of a different age group, and you see the best outcome is obtained in children under 2 years of age and children between 3 and 18 years of age compared to the adults. The reason why children do better is which is multifactorial. The diseases that we treat for children are actually cured by liver transplantation, whether it's biliary atresia or metabolic liver diseases. The risk of recurrence is not there other than for tumors, whereas in adult, at least in the early days, recurrence of disease was a common problem, whether it is a hepatitis C disease or fatty liver disease or alcoholic liver disease. All of these diseases have the potential to come back in the adults. And that's probably one of the reasons why children do much better than adults. Now, the shortage of organ resulted in surgeons resorting to the split and living donor liver transplantation. This shows, this is only a letter to the editor, but the first ever living donor liver transplantation was done in Brazil. And it's organ scarcity, which resulted in really innovations in pediatric liver transplantation. As you would expect, in the early days, we were doing whole liver transplant and waiting for a size-matched organ, which is a pediatric cadaver donor, which was an impossible task. And it was Professor Bismuth in Paris who introduced a concept of reduced size liver transplantation. And from then on, we moved to split liver transplant as well as living donor liver transplantation. The first successful split liver transplant was performed by Professor Pickelmeyer in Germany, and the first successful living donor liver transplantation was performed in Australia by Professor Russell Strong. Now, the living donor liver transplantation in children, the studies which formally looked at it at very similar time. One was in Chicago by Professor Christoph Brollsch, who later on went to Germany to practice, and he did 20 children living donor liver transplantation. And the outcome was extremely good at that time. The graft survival and patient survival was 85% and 75%. And as exactly, so this publication came out in the same year, 1991, the Japanese surgeon, Professor Tanaka, also published on 20 pediatric liver transplantation with living donor liver transplant with very similar results. Now, in the West, living donor transplantation was not so popular, even though Christoph Brollsch did it in the United States at that time. And at King's College Hospital, we worked hugely on split liver transplantation as an option for pediatric liver transplantation. We published our early results in 1998, where the idea at that time was not transplanting children as part of the split liver transplant. The reluctance mainly came from adult surgeons to use the right lobe, as there was an increasing complication rate in the right lobe with split liver transplantation. And we were able to show that the outcome of split liver transplant or the right lobe was exactly the same as if we were using a whole liver for the adults. And if you look at the pediatric transplants, really the outcome was equivalent to that of left lateral segment graft from reduced livers. So gradually the reduced livers slowly disappeared, and split liver transplant really became the standard of care when we were using livers. Now, the argument at that time in the Western centers were that if 30% of the cadaver organs could be split and used for pediatric, there was no need for living donor liver transplantation. And again, this came from the surgeons here are all people who have worked with Christoph Brollsch, who are proposing that it should be a split liver transplant rather than a living donor liver transplantation in the Western world. Now, leaving that aside with pediatric transplants, what we were working at is also transplantation for very small children and getting the outcome for transplantation of very small children right. Now, when the children who were transplanted were less than 3 months of age, this is an issue because children who are less than 3 months of age were much smaller. Their weight was generally 3 to 4 kilograms, and implanting a left lateral segment was a huge issue. And when you look at this publication, which I did in the early 90s, you can see almost 50% mortality when transplantation was done under 3 months of age, and most of them were also acute liver failure as an indication. Now, this is one of the common problems when you use a left lateral segment in very small children. This is a 15 lateral segment weighing around 300 grams into this child. It's impossible to close the abdomen, and there is a problem with the outflow because the liver doesn't sit inside the abdominal cavity. It's pushed out, and therefore there is a partial outflow obstruction as well. And probably one of the reasons why, and there is a huge amount of fluid loss when you put a silastic mesh here, and these children are very small, and to maintain also fluid balance becomes very difficult in these children. So at that time, we proposed what we called a monosegment liver transplantation, even though it wasn't technically a pure monosegmental graft. It was more or less a non-anatomical reduction, and that dramatically improved the outcome of transplantation for the neonates, so for children weighing less than 4 kilograms or less than 3 kilograms in weight. And most of them were done as part of a split liver. And this is a pediatric donor, which is really further reduced into a very small left lateral segment for transplantation. And you can see the blood vessels are all quite long and big and not very difficult technically to implant these livers. And what I said about, previously it was a non-anatomical reduction where you're actually only preserving the segment 3 vein and taking off as much as the lateral aspect of the left lateral segment to do this. And in this way, we have done many monosegmental or hyper-reduced grafts, and the outcome has been equivalent to that of left lateral segment graft. One of the problems when these babies are very small was the thickness of the graft. Even when you said this is a left lateral segment graft, which has been reduced on the lateral aspect, it's been reduced on the inferior aspect, but still the thickness of the graft is a huge problem. And these children, it's impossible to close the abdomen. And if you actually close the abdomen, they'll have huge problem with coming off the ventilator because they'll have a huge amount of pressure on the diaphragm, and post-operative weaning off the ventilator becomes a problem. And therefore, they require meshes like this. This is a PTFE graft, which is used for closing abdominal wall. And 2 weeks later, you can remove them and close only the skin. And 6 months later, we bring them back for closure of the abdominal muscle. And in terms of ischemia, it's not been a huge issue. These grafts may be associated with higher enzymes in the post-operative period, but that's not been an issue for these children. Now, this is Professor Kasahara, who works in Japan, Tokyo Children's Hospital, and he had an interest in he has an interest in pediatric liver transplantation, and he devised a technique for reducing thickness of the graft. And we've been friends and working together for many years. And when he published this technique for reducing the thickness of the graft, he discussed and was kind enough to include me as a senior author of that important paper for reducing thickness of the graft. And he always proposed that if the GRWR was greater than 4 in the children, the outcome has not been good, at least in his center, and therefore he proposes hyperreduction or a monosegmental graft when the GRWR is greater than 4 in these children. So if you estimate a left lateral segment to be 250 grams, you can't transplant it for a child less than 5 kilograms. So most of the left lateral segments are about 250 to 300 grams, at least in our experience. And if you have to transplant a child less than 5 kilograms, which is around 5 or 6 months of age, you will have to do a monosegmental transplant, according to what Professor Kasahara is talking about. But we find that it's not just GRWR of 4, which is important. We have found that in many children, we were able to close the abdomen and not hyperreduce these grafts. And it's a multifactorial problem. It's to do with the thickness of the graft, really, and also with the abdominal cavity. Children with biliary atresia have large livers, and therefore you may be able to implant larger grafts into these children as well. So this is the general concept. You can get an idea when you look at the CT scan of these children. If the liver grafts looks long and thin, there wouldn't be a need, the thickness of the graft won't be very, very much, and there wouldn't be a need for further reduction of a left lateral segment to a monosegment. Whereas if the graft is very stumpy and very thick, you may have to do a further reduction in order to obtain a monosegmental graft. So, and also you need an anatomical reduction. In this one, you can actually take off the lateral aspect of the graft when the graft is thin and long, like you saw in the previous picture there. In this one, you can see that the lateral aspect can be excised in order to reduce the volume of the graft. And it is this way that we have been able to perform very small children. And in this family, they lost 2 children to congenital hemochromatosis, and the 3rd child was diagnosed to have congenital hemochromatosis even before birth through amniocentesis. And then when the child was born at 5 days of age, the child had acute liver failure, and the child had a monosegmental graft from a cadaver liver, and did extremely well. And they have another child who's now a doctor, and this girl is a lawyer now. She was a law student 2 years ago when I met her. And this is the child who was transplanted at 5 days of age. And this girl is on very minimal immunosuppression, has never had imaging of her liver. We don't even know how her liver looks like. And now she's or give confidence to the public. I think it is also an important role for us to show people how well children can do after transplantation. Now, talking about complications, I won't go too much in detail into complications of pediatric transplantation, but one of the complications that we commonly encounter is portal vein flow in children with biliary atresia. When their portal vein diameter is less than 3 millimeters, you often get very poor flow in these grafts, and the risk of portal vein thrombosis is very high in the immediate postoperative period. And these children require, this is a CT scan which shows that the diameter of the portal vein is almost the same as the diameter of the hepatic artery, about 3 millimeters or less. And these children will require further techniques which have been described elsewhere many times. An interposition graft is what is my personal preference. People have used an incised longitudinally and put a patch graft in order to increase the diameter and improve the flow. And this is a common problem. Here you can see a very small child with the left lateral segment from an adult with a left portal vein, which is much bigger in diameter compared to the child's portal vein, which is much smaller. And there is also this problem of matching it up because this is much more inferior. The left lateral segment is much more, the vein comes much more inferior. And if you force them together, you may have kinking of these, and that's why an interposition graft would be a better technique than other techniques that have been described that you saw. There is the outcome of the interposition graft inflow into the left lateral segment. We also note that children with biliary atresia who have very dense adhesions have a risk of bowel perforation, and one needs to be very careful in the postoperative period to diagnose it. It's not always easy to diagnose when these children are have had recent surgery and also are on steroid therapy and may not have the systemic response to bowel perforation. And one needs to be really very vigilant about diagnosing peritonitis in children in the immediate postoperative period. The other problem, when you're not very careful with the dissection of the liver near the suprahepatic cava, is a diaphragmatic injury, and this can result in children not being weaned off ventilator very rapidly. And when you actually see that children are not weaning off, one needs to suspect a diaphragmatic, right diaphragmatic palsy, and you can diagnose that by paradoxical movement of the diaphragm. And if that happens, then you may need to have plication of the diaphragm in order to get them off a ventilator. I've had an interest in auxiliary liver transplantation in children as well, and have published this publication is 2010 in Annals of Surgery on 14 children who had auxiliary liver transplant for acute liver failure. And children regenerate their livers much better than adults and probably are more suitable for auxiliary liver transplantation. There are some issues related to, and there have been many reviews on the subject, particularly with relation to weaning and also finding out whether there is going to be a portal steal with a native liver. You can see that this is an acute liver failure which is attempting to regenerate, and this patient may be most suited for auxiliary liver transplant. One of the problems you face is that the adult, when these children are very small, the adult left lateral segment may be too large, and there may not be room to put in to do an auxiliary liver transplant. But I've always found that even when the graft is very large, the native liver right lobe is stuck on the right upper quadrant, which is empty anyway, left lateral segment implantation. And it's always possible to do auxiliary liver transplant for acute liver failure in children. And this is the CT scan to show how well they regenerate. The first picture is a native liver is very small, the one you saw before, and the graft is very large. Over a period of time, the native liver on the right side is regenerating. And once it's regenerated well, you can slowly withdraw immunosuppression. And when you start withdrawing immunosuppression, you get multiple episodes of rejection, which will result in atrophy of the graft. What you see as a very large graft in the first picture has resulted in complete atrophy. And after that, you can withdraw immunosuppression in these children. And that is particularly relevant in countries like India and very much so even in the Western world, because these children don't have to be on lifelong immunosuppression. I've also had an interest in auxiliary liver transplant for Kriglan-Adja syndrome. And again, this is in the late 90s publication, where we have shown that an auxiliary with a left lateral segment can completely correct the hyperbilirubinemia in Kriglan-Adja syndrome. One of the problems for auxiliary in metabolic liver diseases, the native liver is healthy, unlike in acute liver failure, and therefore provides a free, the portal flow peripherally will go to the native liver, and the auxiliary transplant, which may be slightly stiffer, the graft, because maybe low-grade rejection or whatever, will result in steel into the native liver. So for this, not for the acute liver failure, for the metabolic liver disease, I've always proposed that you have to have a banding of the native portal vein. Therefore, you can actually preferentially shunt the blood into the graft, and therefore you won't get the problem of graft atrophy. So graft atrophy has been a particular problem for Uphold for metabolic liver diseases. And that technique, again, has been described by our group many a times. And the other problem for Uphold for metabolic liver disease has also been that people are very confused about the indications for Uphold and have actually done transplants, auxiliary transplants for conditions where they should not be doing Uphold, resulting in bad outcome. And one interesting aspect that we have done in India is swapping really what is called an auxiliary liver with domino. So we had two children, one with propionic acidemia and one with Kriglan-Adja syndrome, and we took the left lobe of a Kriglan-Adja child and gave it to propionic acidemia and a propionic acidemia child's liver into Kriglan-Adja, which really corrected the underlying metabolic disease of each other, resulting in transplantation without a donor, without an external donor, whether it's a cadaver or living donor liver transplant operation. Now, I went to India in 2011, and it's about 10 years now. Until the end of 2020, we have performed over, in the Chennai alone, in Chennai Center alone, over 2,000 liver transplant. Now we are coming close to 500 pediatric liver transplant in our program in Chennai. And last year, I mean, this is not the full number for 2020. I've not corrected it. Because of COVID, the numbers were slightly smaller. Otherwise, we perform more than 60 pediatric liver transplantation per year. And I believe, as I said at the beginning, it's been one of most satisfying of the works I do in order to see children who come to you extremely sick, and 3 months later, they look, it just transforms the lives of these children. This is again a child with PFIC. You can see with the intense itching, thickened skin, and 3 months later, the pigmentation and everything resolves, and the quality of life for these children improves dramatically. And we have popularized this. A lot of these children are funded by the government itself in India, in our part of the world. And we have had the health secretary to come, and we have shown how well these children have done who are being funded by the government. And this is also an important aspect of the work we do as transplant surgeons in order to make people understand that it's in fact not a burden for the family to have their children transplanted, because their quality of life improves tremendously. And now with immediate outcome having been sorted out, one needs to think about the long-term health of these children, reducing immunosuppression, working on tolerance, their education and sexual health, all of this people are taking an interest in, and also the adolescent medicine, where people are growing up and becoming adults. It's a particularly difficult time for these children because stop medication is a common problem, and this is again evolving as a new specialty in the field of pediatric liver transplantation. And the final thing that I would like to talk about is the developments for donor and the health of the donors who are donating. The left lateral segment is a relatively small operation, and this results in large scars in the abdomen, and a lot of these are young mothers who are donating for their children. And there has been an interest in minimally invasive donor hepatectomy, particularly for children, for the left lateral segment, but also for the right lobe. And we took an interest in minimally invasive. I've never been a laparoscopic surgeon, and we only do very minor laparoscopic surgery. And we took on this into the robotic left lateral segmentectomy. This was particularly useful for me at a time when during the COVID period, when a lot of the work was COVID work, and we shut down for 2 months, and I had the opportunity to train in the exercise system. And now we, for the last 1 year, we do all left lateral segment donor and some selective right lobe donor through this robotic technique. And that's really transformed the outlook for these children. I just fast forward it. This is, I think those of you who are surgeons who worry that you may not have a huge expertise, this is the ICG that's got an ICG camera inbuilt with it, so you can actually visualize the robotic surgery, which is very similar to open surgery. If you're a good open surgeon, I'm pretty sure you'll be able to learn robotic surgery extremely quickly. We published and we have sent the whole program to Annals of Surgery, and we also did a monosegment transplant, and I feel that it's very easy to do a monosegment transplant with the robot, and that's been published in Pediatric Transplantation. We have currently performed about 40 left lateral segment donations using the robot, and we have now started doing the adults, and we have done 7 adult right lobe donor hepatectomy. And I think that this is the future really, and it's important to keep up with the advances in the field of liver transplantation, so that not just the children who are being transplanted have a good outcome, but also the donors who are donating also have much less problem with their scar, and in the long term have issues with long incisions and problems with that. Thank you very much. Thank you. I can't hear any of the other people other than the podium. I can't hear anyone else from here. Only the podium mic is audible to me.
You mentioned adolescent patients in the adolescent period from 11 to 12, 13, 14. It's difficult to monitor. They are non-compliant to treatment, immunosuppression. Do you suggest or you do regular biopsies for this age group?
Not at all. I think they'll run away, I think, if you do regular biopsies. It's a special, that age group is particularly difficult because most of the children who have had transplantation at a very young age group are not aware of their illness, unlike the larger children or the adults who have suffered from liver disease and have transplant. So they don't have a memory of the operation, and therefore they feel that taking medication, the parents are forcing them to take medication. They've never been unwell. And when they are 12 or 13 or 14, they feel that there was no need, and it's been, thrusted upon them. And therefore, there is a high incidence of children stopping medication. There have been many retransplants done in that age group. So, and also when you transfer these children from the pediatric age group to the adult hepatologists and the adult surgeons don't really look at them in the same way as the pediatricians have been looking after them. So there has always been an issue that they are treated like adults and not monitored or looked after as well as a pediatrician. That's why you find that many of the pediatric hepatologists who are looking after transplant patients don't release them to the adults until they are 25, 26, First they come with their mothers, and then they come with their girlfriends, and then they come with their wives and children, and the pediatricians never let go of them. And that's why it's important that the transfer is made in a safe manner. And that's where the adolescent medicine comes, where a group of interested pediatricians and adult clinicians join together to look after these children. Your point about biopsy is, in the early days, we used to do protocol biopsies at 5 years of age and 5 years post-transplant, 10 years post-transplant. These are mainly really for reducing immunosuppression. Some centers stop steroids. There are some centers like King's who have had them on a low dose of steroids. And also to look for really long-term fibrosis in these grafts, even though they may have a perfectly normal liver function test. And there is a lot of interest in chronic antibody-mediated rejection, which causing fibrosis as well. So that's a completely different subject matter, actually. We can discuss in detail about that. But the protocol biopsies are primarily made to look at long-term graft fibrosis or if there is any injury to the liver with respect to reducing immunosuppression.
Thank you, Dr. Ron. Dr. Hisham Abdelkader, a pediatric surgeon, will have a question to you, please.
Thank you.
Dr. Rila, thank you for your extensive experience with pediatric liver transplant. We have I would say, a similar program that had similar outcomes. I mean, it's interesting to see that you see also diaphragmatic injuries and you manage them during surgery. And the question I was going to comment hugely on the portal vein mismatching. You said you do the graft. What is the patency rate for these grafts?
Yeah, see, we have the advantage both in UK as well as in India of having iliac vein graft that we get from cadaver donors. So most of our interposition grafts are cadaveric iliac vein graft, which are cryopreserved. And we have not had long-term stenosis or thrombosis of this. But if you were to use PTFE as an interposition graft, that would be a problem for long-term patency.
Sure. The second comment is, how do you manage your biliary problems? I mean, I think that pediatric surgeries, pediatric programs are different from the adult ones in managing the biliary complications, because usually we tend to reoperate rather than doing an endoscopic maneuvers too much.
Yeah, I mean, as you know, most of the patients, biliary atresia obviously have a Roux-en-Y hyperechogenostomy. And most children, I would say under 10 years of age, even if there is a good bile duct, I would do a Roux-en-Y hyperechogenostomy. So there is no access for endoscopic dilatation of biliary stricture. But I have to say that, at least in my experience, the biliary problems in children are far, far less than adult right lobe living donor liver transplantation. Now, when we do get biliary, you're right in saying you reoperate, but I'm a believer of PTBD and dilatation. Wherever you have a bowel anastomose to the bile duct, you can have a much higher success rate with dilatation, rather than a duct to duct where there is an element of ischemia at the type of anastomosis. Yeah. Whereas a hyperechogenostomy usually is a technical stenosis and ischemia at the site of anastomosis is much less common than in a duct-to-duct that you see in an adult right lobe. So if you ask me, I would try a percutaneous transhepatic dilatation once or twice before I would offer an open surgery. And open surgery also is not so dangerous in children compared to, many. I mean, I like, in fact, open hepatojejunostomy, even in adult living donor liver transplantation, more so than most people. But in children, it's even easier because the Roux-en-Y anastomosis, to take it down is easier than a duct-to-duct anastomosis taking it down. The artery and the portal vein are far away. The injury to the artery is extremely rare because it's coming from the left side, far away from the bile duct anastomosis. So, and if you want to sort these problems out in one go, I think resurgery is a good option.
Sure. The last question is, would you care to comment about the situs and the preduodenal portal vein situations? Because we had an interesting case that the preduodenal portal vein actually caused duodenal obstruction, and we had to do a duodenectomy for this child. So comment on the situs and the preduodenal portal vein?
Yeah, it's a subject. I think I've published a few papers on this, actually. You're right. Biliary problems are common. They also, in the situs inversus patients, there is also an absent caber, which is very commonly seen. So you have to do an anastomosis to the suprahepatic left hepatic vein, end-to-end anastomosis you have to do, so that results in a slight rotation of the graft. I mean, it's a special problem, really, situs, because the left lateral segment has to be placed in a very central position. The spleen is on the right side, so it's more on the left-hand side than you would like, more than in the right-hand side. And I think everything it's not so difficult to overcome, I have to say. I think it's much more difficult to do situs inversus using a right lobe graft in an adult. I've done adults as well with situs inversus, because you got to place a right lobe graft in front of a spleen, for instance, where there is no room. So it gets pushed to the midline. Whereas in children, I think situs inversus is less of a problem.
And the preduodenal portal vein?
A preduodenal portal vein is not a problem at all, actually. One of the problems with preduodenal portal vein is surgeons often miss it and ligate it, thinking it's a collateral. And then you go down and see that there is no portal vein, and you look back to see what you have tied, and you've tied a small vein, and there are biliary atresias as well. Usually it happens in biliary atresia where there is a hypoplastic portal vein. Once or twice I've ligated it inadvertently and then didn't find a portal vein posteriorly, and then look back and there is a tie and you trace it down. Other than that, I think preduodenal portal vein are not a particular problem, but sometimes when they are very small, like in other biliary atresia, you may need an interposition graft for them. Most of the preduodenal portal vein are quite small in size.
Thank you. Thank you.
Thank you, Dr. Ella, for the beautiful and really very informative lecture. And you went all across the whole spectrum, from the old times and the nostalgia of Professor Starzl and Brolsch and Tanaka. You remind me by these good old days, up to the down to the Appelt, and now the robotic surgery. We just received for the very first time in NSHAMS the robot, but we didn't have the advantage of the Da Vinci that you chose, and you are relieving me that you didn't have enough laparoscopic experience, but you had the courage and you used the COVID-19 time to gain the experience, and you started this program. So maybe we'll need you to start with our. We purchased the CMR, you know, the Cambridge.
I think they had a good financial deal. I mean, they came and met me as well. But I wanted to go for well-established, and also in terms of instrumentation, they don't have everything. We are looking to buy a second robot, and I was looking at CMR. Maybe I'll go and try it. I mean, there are a huge advantage to the Da Vinci Xi, and Medtronic have also come up with a new that they are coming up with. They're releasing it. It's already there. I think with time the costs are going to come down for patients. My personal opinion about robotic is it's there to stay. and gradually most people will have to, because it is very, very good for patients, for the donors, and I would advise people who are embarking on not to hesitate and to get started with robotic donor hepatectomies.
And do you think there is a huge difference between the CMR and the Da Vinci one in terms of the left lateral segmentectomies and
probably not. Probably not. But when I speak to people with the Cambridge CMR, they say, I don't know if that is true. Maybe the competitors are spreading a rumor. They were saying there was a tiny bit of delay. A tiny bit of delay may not be very safe, because if you have a bleeding and if you only see the image a split second later, your vision will be gone. That is one. And in terms of instruments particularly, they've got very limited number of instruments now. They will have to come up with more instruments. The third is, I don't know, the stability, the instrument size are smaller. They are standing on the floor compared to the XI, which comes from the top, and it's quite a rigid, big system. But I would like to try the Cambridge system, and they have asked me to just try it. So maybe I'll try it and let you know. But currently, everybody who's doing it, like in Saudi Arabia, yes, he is doing an XI system. The Koreans also have an XI system. So I didn't want to take a risk, and I went for the XI as well.
Okay. So it's a pleasure having you today with us, and we really enjoyed all the lecture and all your vast experience. And maybe we'll meet physically soon after COVID-19. You're allowed to travel, or you're not allowed to travel?
No, I'm allowed to travel. I'm going to Belgium next month.
Oh, you're going on the 15th? Yeah, I'll try to be there as well.
Sure, we'll meet up. Thank you very much.
Thank you very much. Bye.
I've enjoyed that meeting very much.
Thank you. Bye. اوكي، دكتور ايمان منتصر الحقيقه هي اللي وضبت كل المقابله مع دكتور ريلا، وكان كذا ميعاد يمكن لحد ما واجلنا عشان كنا مرتبطين بالمكان هنا نكون جاهز. ودلوقتي ايمان هتكلمنا على transplantation in the COVID era cases from the real life. وعايز اشكر ايمان وكل فريق الباطنه في او الكبد، ايمان وهاني وهند ومنار ومها، وكلهم الحقيقه على شغلهم اللي بمنتهى الاخلاص وراوند ذا كلوك. وساعات يعني بنرمي عليهم حاجات كتيره قوي ونهرب احنا منها لما نكون تعبانين، ما فيهاش حل تاني غير كده. Thank you Iman for all what you're doing, and the floor is yours.
Thanks, Dr. Mahmoud, for this nice introduction. I'll talk today about liver transplantation in the era of COVID-19. I think it is a very hot topic we should all know nowadays. My agenda for today is COVID-19, the current situation in Egypt, COVID-19 and liver transplant, the management of liver transplant recipients in the era of COVID. For the current situation, according to the newest WHO brief today, we have more than 298,000 cases, confirmed cases, and more than 17,000 deaths, and a total number of about 13 million vaccine doses have been administered. For the situation in Egypt in the transplant, many centers, nearly all centers, governmental and university centers have temporarily hold their activities during the first wave of the crisis. Ain Shams University hospitals, we temporarily held the program from March till July the 13th, 2020. And although operations were temporarily held, outpatient clinics and follow-up continued. And I claimed that our staff made great efforts during this period to follow up recipients, whether through telemedicine and or hospital visits whenever needed. This is the annual number of transplanted patients in Ain Shams from 2010 to 2021. And you can see that the crisis or the pandemic have greatly affected the number. This is the monthly cases from January 2020 till September this month, 2021. We are trying to catch up, but still the number is less than before the COVID-19. For management of recipients with non-COVID-19, the first step is health education. All non-COVID recipients are instructed not to stop or reduce their immunosuppression doses. This is a very important point. A lot of patients came to us saying they heard about stopping immunosuppression for COVID or reducing their immunosuppression. This is very common, so we instruct all patients not to do this without any judgment. The general rules of social distancing, follow-up for any symptoms suggestive of COVID, history of contact with suspected or confirmed cases, and immediate notification of the transplant team. For vaccination, all recipients are advised for vaccines against streptococcal pneumonia and seasonal influenza vaccine, and recipients are advised also to postpone all non-essential travel. For the COVID vaccination, this is a very hot topic, really hot topic. The last ILTS infectious disease statement released in January 2021, they advised that all transplanted patients have to be vaccinated, as well as their health care workers. There are multiple vaccine types becoming available, and this will likely differ in efficacy and duration of immune response. And of these, the live attenuated vaccines and the vector-borne vaccines may not be appropriate for transplant population, although they are not absolutely contraindicated, but it differ, or it better to be a different type. For consideration should also be given to vaccination strategies of live donors prior to donation, as well as all caretakers of transplant patients. Until more information is available, it is recommended monitoring the presence of antibodies every 3 to 6 months in liver transplant recipients and candidates, with close monitoring of liver enzymes in liver transplant recipients following vaccination to ensure the lack of immune-mediated graft reactions. This is a very nice letter about the immunogenicity of the first dose of the messenger RNA vaccine in solid organ transplant recipients in the US. They observed mild peri-vaccine reactogenicity after the first dose, like reported rates in non-solid organ transplanted recipients. However, they found that antibodies was detectable in 76 out of 436 participants. Only 17% of recipients built up an immune response. Also, they found that transplanted recipients receiving anti-metabolite maintenance immunotherapy and older transplant recipient age group were less likely to develop antibody response. This is very nice published data recently published in the New England Journal of Medicine just last month about third dose of mRNA vaccine in solid organ transplanted recipients. And as you can see, the prevalence of anti-COVID antibodies was 0% before the first dose, 4% before the second dose, 40% after the second dose and before the third dose, and reaching 68% 1 month after the third dose. So this study showed that administration of third dose of vaccine in solid organ transplant recipients significantly improved the immunogenicity of the vaccine, with no cases of COVID-19 reported post-vaccination. However, still larger proportion of these patients, about 30% of patients, remain at risk of COVID. So barrier measures should be maintained, and vaccinations of relatives is still recommended. For post-transplant clinic follow-up, we, in the early post-operative period, less than 3 months, we maintain our regular post-operative follow-up visits as per center protocol. However, we tried to limit the number of patients in each visit, the number of the family members accompanying patients, and routine precautions like hand hygiene, facial masking, and social distancing. For patients transplanted more than 3 months. The follow-up was done mainly through telemedicine with the transplant team. Hospital visits and admission are restricted according to the clinical judgment of the transplant physician. This is one of the nice data from the Italian lockdown experience. They found that 62% of transplanted patients would use remote e-health technologies to interact with their follow-up centers in absence of relevant health problems. This is another data from different US centers, and we can find that in the worst weeks of the pandemic, in the first wave, up to 85% of clinic visits were converted from physical to virtual. For management of patients on the waiting list, according to the Egyptian protocol of living donor liver transplantation published this year, January this year, and I was one of the authors, monthly updating the child and MILD score with weekly update for those with MILD more than 25, abdominal ultrasound, duplex, and alpha-fetoprotein every 3 months, and triphasic CT portography whenever needed, with weekly arrangement of the waiting list according to MILD child scores and HCC characteristics. For hospital admissions, for the non-COVID transplant recipients, hospital admissions was very restricted for patients with severe sepsis, those with the moderate to severe rejection, and patients on the waiting list needing admission. For the endoscopy workup, only urgent endoscopies was performed till July 2020. Then we restarted our regular endoscopy since then. And as Professor Hani Dabbous mentioned, we do ERCP for biliary complications, about 2 to 4 cases per week. All patients, of course, all patients are tested for COVID infection before admission. This is our first publication early this year about repeated COVID infection in recipient post-living donor liver transplantation, 2 real-life cases. And this was the first 2 cases of COVID-19 reinfection in the post-transplant setting, and no previous reports of COVID-19 before this. It was the first published reports. Then we have another case of reinfection in the literature later on, and another 2 cases in literature in kidney transplant. For the first case, he was a 49 years old male. He received living donor liver transplantation in 2019 for cryptogenic cirrhosis. He had a first attack of COVID in May 2020, then the second attack about 96 days after. In both attacks, the patient was completely asymptomatic and accidentally discovered to be COVID positive during routine workup before ERCP for his biliary problems. As you can see on the left side, his MRCP showing moderate intrahepatic biliary ductal dilatation. According to our judgment, we temporarily hold the MMF, and the patient was discharged from hospital after 2 negative nasopharyngeal swabs after resuming his immunosuppressant drugs. This is his laboratory workup showing the picture of obstructive jaundice with rising of serum ferritin and D-dimer. And this is his serial CTs in the first attack, second attack, and last CT in this month or the past month, which was completely normal. The second patient was a male patient, 61 years old, received organ in 2017 for HCV-related cirrhosis and portal vein thrombosis. He had 2 attacks of COVID less than 2 months apart, which was astonishing. He was presented in both cases with high-grade fever, cough, dyspnea, diarrhea, hypotension in the second attack, and he was admitted to intermediate care for diagnosis of COVID and sepsis. The second case was more severe. He has lung and kidney affection. He had metabolic acidosis, serum creatinine of 7 milligram per deciliter, and hyperkalemia. We decided to stop all immunosuppressants. And fortunately, the patient responded to medical therapy, fluid therapy, and he didn't need any sessions of dialysis. This is his CT. Can you show it, please? With multiple variable size ground glass capacities. And both patients were discharged from hospital after 2 negative nasopharyngeal swabs, as I mentioned. This is the recorded cases of reinfection, but in the general population, not in transplant recipients. Up till now, there is 17 documented cases of reinfection. So my messages for today, that many questions still remain. Management of non-COVID recipients and patients on waiting list is very crucial. Regular immunosuppression doses are essential, and every effort should be made not to compromise the management of these vulnerable patients. telemedicine follow-up is expected to continue during the near future, and the course of COVID-19 post-transplant is very variable. The spectrum varies from mild to severe disease. Reinfection coexist and should be managed in cooperation or coordination with the transplant team. I'd like to thank you all for your attention. Thanks for all the team in Ain Shams. This is a big cake we received today for the reopening from one of our patients and his daughter. Thank you all.
Thank you, Professor Dr. Iman Muntasser. Any questions from the floor?
The end of this session. Have another session. So the moderator and the chairperson of the third session, please, the floor is yours.